I hope that you are not too tired, and we are going to continue. I would like to share a little bit my experience when I work in more in emergency about radial head fracture and their treatment. I'm going to talk about this part. What I would like to remind you that 30% of all the fracture of the elbow is concerning radial head. 30% of all radial head fracture are associated with other elbow injury, and in 10% of case you have associated elbow dislocation. Few years ago, I was enthusiastic, and I have done a study, scintigraphy, CT scan to measure diameter of radial head and so on. That what was my interest in that study to see what are the maximum minimal diameter of radial head. That in that period we utilized radial head prosthesis, and what was our findings that here between maximal diameter is between 20 and 24 millimeters. That was for us in that period interesting because most of there was only two sizes of radial head prosthesis, 19 and 22. That means 19 we don't need it so frequently, and I published that in shoulder and elbow surgery. But now, what is the contribution of radial head in elbow stability? We can analyze it in frontal plane, sagittal plane, and longitudinal plane. In frontal plane, you saw today that radial head is a secondary stabilizer against valgus stress, and if medial collateral ligament is intact, as you see, their contribution is not so important. But once when you have the complete tear of medial collateral ligament, importance of radial head is much higher. What's happening in radial head prevents posterior elbow dislocation in association with the coronoid process, lateral ligament complex, and medial ligament complex. And finally, in longitudinal plane, radial head prevents proximal migration of the radial shaft in concern with the interosseous ligament. And in conclusion, what we can say that the radial head can be considered as multifunctional stabilizer of the elbow joint. Mechanism of radial head fracture was well described. That's a little bit classic fall on outstretched hand and with some degree of flexion. What you have indirect mechanism of is associated valgus pronation, axial compression. Some studies say that in this moment 90% of body load goes by radiocapital articulation. As you know very well, this is a classic Mason classification, non-displaced, type 2 displaced, and type 3 commutative radial head fracture. But as I told you from the beginning, they are very frequently these fractures associated with other elbow injury, associated with coronoid fracture, proximal ulnar fracture, medial collateral ligament injury, lateral collateral ligament injury, and interosseous ligament. This X-ray classic from emergency, it's when you utilize this Mason classification, there is study who shown that intra and inter-observer reproducibility of this classification is not so good. And you have all the time when you have radial head the fracture, you have keep in mind a little bit this schema of Driscoll. What you need to have, you have to have AP lateral and oblique elbow radiographs, and you have to have bilateral anteroposterior radiographs of the wrist, and in most of cases, after, if you don't want to analyze it better, CT scan. As you know, there is this Mason classification. We added Mason-Johnson type 4. That's radial head fracture associated with elbow dislocation. And there is Hotchkiss also classification type 1, undisplaced or minimally displaced. That means less than 2 millimeters. Hotchkiss type 2, displaced but reconstructible, and Hotchkiss 3, unreconstructible fracture of radial head. Every of us dealing in the practice have his own algorithm in the head, and I'm utilizing this one that you can see. This is that fracture displays more or less. I'm talking about isolated, more or less of 2 millimeters, less 2 millimeters, early motion, more than 2 millimeters, fragment size, is it more than 30% of articulated surface, and so on. All that we can repeat slide by slide. That's Mason 1, undisplaced, so fracture treatment, non-operative, active, early active range of motion. And I'm not so big fan of long immobilization because you are going to have a deficit of extension. Mason 2, non-operative management if fragment is less than 2 millimeters. And if it is, you have to take in consideration that this fragment is not blocking your mobility. Mason 2 fracture, I put you all this on the slides. Block the motion is an indication for surgery. You have to take in consideration the size of the fragment, large displaced fragment considered for osteosynthesis. And today you have this cannulated screw that you can do the osteosynthesis, and you have now the plates. If we are talking still about Mason 2, consider displaced and comminuted fracture involving less than 1/4 of the radial head with a block to motion, and or if it's not feasible, small fragment size, osteoporosis, you can take this fragment out without any problem. But we are approaching now to the Mason 3. That means comminuted radial head or neck fracture. If there is more fragments, risk of complications from or if increase. The goal and the best treatment is to have osteosynthesis, rigid internal fixation, and that it can provide you early mobilization of articulation. Each time that's not so easy. Radial head excision, contraindicated in patients with injury to the medial or lateral or ligament complex or interosseous ligaments. You have all this on the slide, but now we are approaching radial head replacement, and in the case of a reconstructible radial head fracture involving radial head with soft tissue injury, some people propose metallic implants because in the literature and the history, silicone radial head prosthesis had shown too much complication. Another thing that I'm leaving for my colleague who is talking after me about this complex instability fracture dislocation. And I'm coming to the part of my topic that I would like to share with you my personal experience. When you find yourself in the situation of cumulative radial head fracture, as I told you, each time if osteosynthesis is possible, that's the best treatment. And in some case, radial head prosthesis is indicated, and that is a little bit controversy in the literature. As you see, in 2000, in Journal of Orthopedic Trauma, the people from, I think, from Spain had published results of acute excision of the radial head in elbow radial head fracture dislocation, acute excision, and they reported very good results. You can find everything in the literature. And the question, arthroplasty versus internal fixation. And if osteosynthesis is not possible on the market, you have now metallic radial head prosthesis. There is two different concept design. There is a monoblock with a loose fixation in the neck, and there is a bipolar radial head prosthesis from Gide that when I worked in Belgium, that was a little bit our choice. And I published the paper in 2000, that small series, fracture of radial head with associated elbow dislocation, and using floating radial head prosthesis. That is classic Kochler approach. And we was very enthusiastic with the early results. And the mean follow-up of our patient in that period was 2 years. And the results was promising. Why? Because 32 months mean follow-up, utilizing more scoring system. Excellent was 4 patients, good 4 patients, 2 patients had fair results and 1 poor. Concerning complication, we didn't have prosthetic failure, no dislocation, 1 ossification, and ossification, small ossification in the region of collateral medial ligament. 5 patients was completely pain relief, 4 had mild elbow pain, and we have done conclusion of that study that floating prosthesis is well tolerated, can prevent proximal migration of radius, provide stability while the bone and soft tissue heal. And we talk also about importance of automatic surgical technique, advanced modality of postoperative patient management, and so on. But the worst thing that you can have as a surgeon if you continue to follow up your patient in long term, and that's something that we don't like. And we continue to do this prosthesis, and finally we had 51 cases of cumulative radial head fracture in 50 consecutive patients, mean age 50 years, and the follow-up period till 13 years. And what type, there was 11 Mason type 3 fracture, 33 were Mason-Johnson type 4, and 6 patient was with associated posterior montage lesions. According to the Mayo Elbow Performance Index, 14 results were graded excellent, 25 as good. That means 39 patients can consider that they had acceptable or good clinical outcome. But when we analyze our, when we done radiological analysis of our prosthesis, we find that in asymptomatic periprosthetic lucency were present in 27 patients. Sclerosis at the distal tip of the prosthesis were observed in 7 patients. But what was bothering us, that was this progressive loss of bone at the radial neck region was observed in 16 patients, and progressive loosening in the mid-stem region with ballooning was observed in 5 patients. See, on the 51 patients, only 12 patients showed perfect radiological image at the last follow-up. What are the complications on this 51 case that we had? We had one regional sympathetic mediated pain syndrome, one ulnar neuropathy who developed, and we have done transposition of the nerve, one proximal radioulnar synestosis, one posterolateral subluxation, 2 overstamping of radial head prosthesis, that we can say that 4 patients presented transient posterior interosseous nerve palsy who recover really quickly. There were no case of infection. I can share some radiological evidence of synestosis in one case. What I am talking about absorption at the proximal part on the neck of radial head. And here you can see ballooning at the middle part of the stem. And what kind of explanation we try to speculate it, why there is this loosening. You have to know that this type of prosthesis, that is, they have a small radial head on the stem. That's and you have polyethylene enclosed in chrome cobalt, and the contact in the capital radial articulation is diminished for 2/3 because small dimension, and the size of polyethylene here is only 3 millimeters. A very big load is going on the radiocapital joint, and if you utilize experience with the hip prosthesis and the polyethylene that they need to have at least 8 millimeters, that can be cause of this particle debris who goes and produce this bone destruction. You have here displacement of the stem, and when you analyze this 50 or 51 patient, you had this case who had only commutative radial head fracture, that we called it that injury was less important, and on the final, that's flexion extension deficit. You see in the first group, that means they have as the first injury, as the injury of the elbow was more important on this group, the results was less good concerning mobility. Same thing is that's with the pronation, and the same things with the loss of flexion. What conclusion we have done on the basis of our study? That patients treated with floating radial head prosthesis have midterm satisfactory clinical outcome. But clinicians should be aware of possible silent progressive prosthesis loosening with massive bone destruction of the proximal radius. That these patients have to be checked periodically to see what's happening. Thank you very much.